Okay.
It's Karen. Okay, so our speaker today is Tina Smith,
Formal.
and she's received her MA in Social Gerontology from the CSU in Warrenburg, Missouri, and she has been working with the Bexar County Area Agency on Aging for the past 8 years, and she's been managing the local ombudsman and currently has as the Access and Assistance Coordinator, and she supervises 3 of the agency's largest programs, the Information Referral and Assistance, Benefits Counseling, and Care Coordination, and she works many hours to educate the public on the resources available in the community, and as well as public benefits and private health insurance. And then today she's going to educate us on this very important topic of Medicare Part D. That's a puzzle for us. So thank you for coming and helping us try to figure it out.
Sure. I was wondering if I could do a favor. I have to keep record of who I talked to. Can I just pass around a piece of paper and you sign in? That's all that I need, or just your...
Not that much, so it's like...
Okay, just briefly, those are some brochures, but briefly, we are a federally funded program. Our funding comes out of the Older Americans Act, and every county in the country is covered by a AAA. 28 here in Texas, we cover strictly Bexar County. We're housed at the Alamo Area Council of Governments, and that covers a 12-county region, so there's actually 2 area agencies on aging there. We cover strictly Bexar County, then the Alamo AAA covers the 11 surrounding counties. But basically, we provide services for people 60 and over. And really, that's our only requirement, is that they be 60 and over and live here in Bexar County for us. We don't have income or resource criteria to be eligible for our services, so they don't have to make below a certain amount or have below a certain amount in the bank. But the services we provide services 2 different ways. On the left or right-hand panel, inside that brochure, those are services we contract out for. So essentially, we provide funding to different agencies in the community that provide those services, such as the City of San Antonio for the nutrition programs through their senior sites, as well as their transportation program, Christian Senior Services for their Meals on Wheels program, things like that. A bulk of our funding does go towards nutrition and transportation. The other way we provide services are directly, and that's what's in the middle-hand panel. And what those services are, just briefly, are information referral. So people are looking for different resources in the community. They can give us a call and we can give them that information. We have an ombudsman program, which is a nursing home and assisted living advocacy program. So if anyone's living in a facility or as a family member living in a facility and are having problems, an ombudsman can step in and help try to resolve those issues. Also, if somebody is having to look for a facility, we can't recommend facilities or tell people which facilities to stay away from, but we can give them information, more information to make a better informed decision about the facilities, complaints received, information about how long the administrator's been there, which makes a difference in the level of care. Another program, our next 2 programs pretty much go hand in hand. They're both case management programs. One is a care coordination program designed to assist the senior who is living at home by themselves and really taking care of themselves. They don't have any family members or friends stepping in helping them out. If they've been recently discharged from a facility, whether it be a hospital, nursing home, or rehab center, we have case managers that can go out and help set up services, whether they be services from the community or services that we're able to pay for. We can pay for short-term home health services, up to 3 months of home health services. We can do ramps and grab bars, refrigerators and stoves, medical equipment, medication, the emergency response button, the life support button. If something has happened and they can't get to the phone, we can pay for up to a year of those services. The other case management program we have is designed for the caregiver, a family member or friend who is taking care of a loved one who's 60 years of age or older. Caregiver can be any age. It doesn't have to live with the person they're providing care for. It's just that the person they're providing care for needs to be at least 60. Same services I just mentioned, the home health services and ramps and grab bars and things like that, but we can also provide respite care for the caregiver, whether it be in-house, in-home, have someone come into the home. Again, it's 3 months. You can pay for up to 3 days a week for 3 months of adult daycare, and then also institutional respite as well, generally 4 or 5 days of institutional respite. We also have counseling available for the caregiver if they need that. And then on the kind of a side program on our caregiver program is our grandparent program, because we recognize that there are a lot of grandparents raising grandchildren. The grandparent, actually this age just changed with the passing of the Older Americans Act last week. It used to be 60 and over, but now the grandparent's age is 55 and older. So if the grandparent is 55 and older and they're raising a grandchild under the age of 18, there doesn't have to be a legal relationship, but just the grandparent needs to be the primary caretaker of that child. We can help. We have support groups all over town. We have counseling available for both grandparent and the grandchild, education sessions for the grandparent, as well as we can purchase things for the grandparent if they need some assistance purchasing things for their grandchildren, whether it be school uniforms, school supplies, glasses, formula, diapers, things like that. We can assist. In the summer, we're able to pay for a couple of weeks of day camp through the YMCA. So those services are available. And then our last program is our benefit counseling program. And this is actually two sides of this program. One is that our legal side, we contract with the San Antonio Bar Association. We can pay for basic legal services for seniors. If they have a simple will, they need drawn up, power of attorney, probate. What we can do is pay for the attorney's time for those issues. We cannot pay court costs or filing fees, but we can pay for the attorney's time to do those documents. And then on the other side is our benefit counseling program, and we have staff and volunteers available to answer questions and provide assistance on public benefit issues, Medicare, Medicaid, health insurance issues, things like that. If people have problems with them or questions, they can give us a call and we can help try to work that out for them. The Medicare prescription benefit, we try to do a lot of outreach and education about this, as well as we can help people screen for which plan is going to be best for them. You know, we don't sell any insurance plans, so we're an unbiased source for that. So anyway, that in a very, very brief nutshell are the services that we provide. You can access them by that bottom phone number, the 362-5254. That's our main information line.
Is this a federal or a state agency?
Federal.
It's a
Well, we're
federal.
federally funded. It's funded out of the Older Americans Act. It comes down through Administration on Aging, but it comes down through the State Unit on Aging.
Okay.
But then it comes down through the Alamo Area Council of Governments, which is a quasi-governmental agency. So actually, I'm not a state or federal employee, but my salary is paid by federal funds.
Is that out of like one of the block grants that are given to the state, or?
No, it comes directly from the Older Americans Act.
Oh, great.
I mean, they're federal dollars that
Yeah, that's
provide
good.
the funding for it.
So this is one of 22?
This is one of
agencies
28
in
AAAs here in Texas. There are well
Texas.
over 600. Every county in the
Okay.
country is covered by a AAA.
this? Okay.
So, I mean, if you know someone in another part of the country or another part of the state, you
Okay.
can give us a call and we can give you that phone number. Or you can go to the Administration on Aging. They list all the AAAs in the country.
Okay.
You mentioned that it has to be a certain income.
No,
No income.
no income. Strictly age and where they live are the determining factors. Now, income is something, most of our clients are low income. And I'll be honest with you, the Administration on Aging is looking for future years, possibly looking at some cost sharing. But right now, we're not allowed to charge anything for our services. But because most of our clients are low income, but we
Like
don't.
older adults would have like transportation and like all the services that you mentioned.
Well, they're available. Now, some of the services like transportation is, there's a tremendous shortage. Transportation and home repairs are two not very well met needs here in town. So we provide funding for transportation, but it is limited. It's through the city of San Antonio, so it's doctor appointments and things like that. But oftentimes people have to call 4 or 5 days in advance.
On the caregiver program for grandparents, is there like a long list?
No, not really at this point.
And do you make home visits, or I have to get grandparents up there?
It depends on what the need is. Some of the services we can provide directly over the phone. You know, if they just need help purchasing diapers and formula for their grandchild, then we could do that directly over the phone. You know, if they needed a ramp, or you know, because they have a disabled grandchild they're taking care of and they need a ramp, that would take a case manager out, and that could take several weeks up to a couple of months before we can get a case manager out to what they need. But again, the support groups and the education classes and the counseling, that can be, we just tell them where those support groups are and the education sessions and things like that, and they can go to those. Also under our grandparent program, for the legal side, we have attorneys that can help if they need help with adoption, custody, or guardianship. We have attorneys that can do that. Again, we don't pay for the court costs or filing fees, but we can pay for the attorney and the ad litem attorney to do those services. Generally with those, it takes 4 or 5 weeks to actually get the attorney, because we have to send the referral over to the San Antonio bar. They match up with the attorney and then call us, and then we'll call the client and say, this is the attorney's name and phone number, and it's up to the client to make the appointment with the attorney. Okay, any other questions about our services? Just so you know, my phone number, if you need to reach me, is on the back cover, the 362-5217. That's my direct phone number. My name is Tina Smith. Again, okay, Medicare Part D. It's come around again. We're back. We're just about ready for round 2 of Medicare Part D. We'll see if this is as bumpy as it was the first time. I'm sure it's going to be a rough few years before this thing may get straightened out. Let's see, which one is it? Okay. What I start off doing, oops, let's see. Oh, actually, okay. Basically what I'm going to go over first are the basics of the benefit, because really if you want to help a client with navigating through the whole Medicare Part D system, you need to understand the ins and outs of what the benefit is. Basically what Medicare has done is that they created a basic benefit. They said that this is what we want the basic benefit to look like, and they contracted with all these companies to provide that benefit. So those companies had to provide at least the basic benefit, but could also provide enhanced plans with more benefits. The basic benefit looks the same for both years. It's just the costs associated with them are going to be different. This year, for the remainder of this year, the plans, Medicare said that the plans could have a premium if they wanted. The premium ranges this year from $1031 to $6841 for the standalone prescription drug plans, and those are drug plans that are offering strictly the prescription benefit. That's all you'll get when you sign up for a standalone or PDP, if you see that acronym.
So that's a monthly cost?
That's a monthly premium, and this is
Okay.
in addition to their Part B premiums and whatever other health premiums that they might have. The MAPDs, these are the Medicare Advantage prescription drug plans. These are the health plans, the HMOs and the PPOs and the private fee-for-service. So if you enroll in the MAPD, you're getting the health plan along with the prescription drug plan. And this year the premiums range from $0 to $49.47. I mean, for 2006. Now next year, the premiums. Let me go ahead and pass these out so you have them, because these are the plans for 2007. Let me keep one in. Let's see. These are the standalone prescription drug plans, and these are the Medicare Advantage prescription drug plans. But the standalone prescription drug plans, the premium is going to range from $11 a month all the way up to $96.50. So it depends on what plan the person enrolls in. With the Medicare Advantage plans, the premium is going to go from $0 to $121.20. It's the highest premium that I've seen. So the plans are allowed to set their own premiums. Now the plans this year are allowed to have up to a $250 deductible. So they can have a $250 deductible, they can have a $100 deductible, or they can have no deductible. It's up to them, but it can't go above $250. Next year it will be $265. Will be the maximum deductible the plan can have. Now once the person meets the deductible, if there is one, that's when the benefit essentially goes into effect, and that the plan will cover about 75% of the medication, and the beneficiary will have about a 25% copay. The reason I say about is because most of the plans actually have set copay amounts. Instead of a 25% co-insurance, it's a set dollar amount. So the beneficiary will actually have a copay rather than a co-insurance. So it won't be a percentage, it will be an actual dollar amount that they pay. Those range from plan to plan. It depends on the medication. Now, the plans are going to look at two numbers. The plans in Medicare will look at two numbers as the year goes on. The first number they're going to look at is the total cost of the medication. That's not just what the person is paying and not just what the plan is paying, but what the total cost of that medication is. So that medication may cost $100. The plan pays $80 of it and the beneficiary pays $20 of it. What's going to go into that $22.50 is that $100 amount of that medication. Once the total cost of the medication for the year, for this year, reaches $2,250, that's when Medicare will stop paying and the donut hole starts. The beneficiary will be responsible for 100% of their medications. Next year, the total cost will have to go up to $2,400 before the donut hole starts. Now, the second number that the plans are going to look at throughout the year is the what they call the out-of-pocket expenses, or you may see the acronym TROOP, True Out-of-Pocket Expenses. That's what the beneficiary has been paying into for their prescriptions. It's the deductible, it is the co-pays or co-insurance, and it's the money that they've been having to pay for 100% of their medications in that donut hole. Once that number reaches $3,600 for this year, that's when Medicare will kick back in, and they call that catastrophic coverage. Medicare will cover 95%, and the beneficiary will pay 5% of the prescriptions. And you may have seen that bottom number. So that's what the donut hole is. Those are the amounts. Now, it's been confusing because you're looking at two different numbers. Really, you're not looking at the same. Your different numbers, different amounts are going into each of those categories. So the number for the $22.50, the total cost of medication is going to increase a lot faster than the out-of-pocket expenses of the Medicare beneficiary. And just a note on the out-of-pocket expenses, it does not include the premium, and it does not include any medications not on the formulary of that plan. You may have seen the number 5,100. Medicare figures that the approximate total cost of the medications by the time the beneficiary reaches that $3,600 out-of-pocket expense will be around 5,100, but that's a flexible number. Really, the number they're going to look at in relation to the donut hole is that $3,600. This year, it's going to be $3,850 for next year. So essentially, the donut hole next year is going up. It's going to be about $150 larger next year than it was this year. So it's going to be a little bit bigger. A lot of people, they figure that the average beneficiary has already reached the donut hole. They figure they did that sometime in September. And really, if they're just now reaching the donut hole, they're not going to have coverage for the rest of the year. They won't have coverage until the benefit starts again in January, when you start all over with that. So that's what the basic benefit. What I passed out to you, just so you can see what the plans look like. If you look at the one that says the Part D standalone prescription drug plans, just so you, and you can find this on the Medicare website. If you go to medicare.gov, there's a link that shows all the different plans. But on the column on the far left, that's the actual name of the company that's offering the plan. But you can see a lot of the companies have several different plans. So they'll have a basic plan, and then they may have a couple of enhanced, what they call enhanced plans. So they may have additional benefits. So just for example, the first one, Aetna, they have 3 levels of plans. Now the Aetna Medicare RX Essentials, that's their basic plan. That's going to look the most similar to what Medicare's basic standards are. They've got co-payments, and they've got the monthly premium for the basic plan is $27.30, and their deductible is $200. And then when that beneficiary reaches the gap, when they reach that $22.50, or actually for next year it'll be the $2,400, then this plan will not cover any medications in that gap in coverage. Their next level of plan is considered an enhanced plan. That one's $41.60, but there's no deductible with that one. Again, that one does not cover any medications in that gap in coverage. Their highest one, their most enhanced one is $69.70. Again, no deductible, but in that gap in coverage, they'll cover generic medication. So if that beneficiary is on any generic medications, that plan will continue to cover the generic medications.
So if they're planning out for the year, then they have to plan for, if they have a lot of meds, they have to plan for $3,600 probably coming at the end of the year.
Right.
And well, at least for that one plan, plus the drug deductible, because that,
They have to look at it, if they have a deductible, they're gonna have to meet that first.
okay.
So all the costs that they might incur, they need to look at the premium, they need
Plus
to look
the
at the
premiums.
deductible, the co-pays, what each of the co-pays are, and this sheet doesn't tell you that. And then,
The out-of-pocket expense doesn't cover the co-pays?
it does, yeah, the
No.
co-pays are included in that. I mean, this
Okay.
sheet doesn't tell you what the actual costs
Okay.
are for each medication. And then, the money that they have to pay in that gap in coverage, when they're having to pay for all of their medications,
Right.
that's what's gonna go towards,
Oh, plus the medications. that
plus
are
the
covered.
medication in the donut hole.
Because I'm just sort of trying to figure out what they need to plan for on a yearly basis.
Right, yeah, if they look like, because when you do a screening, the best place to do a screening is on the Medicare website. You go to www.medicare.gov, enter in the medications, the dosage, how often they take them, and what pharmacy they go to, because all of that plays a factor in the cost of the medication. And so when you do that, it's going to give you a list of plans from least expensive to most expensive, and it's going to give you the breakout on the cost. So you click on the plan name, and I encourage you to go play with this if you help beneficiary, just so you've got a picture of what this looks like. It will give you the cost of each medication, so you can see what it's going to cost you. It gives them what it's going to cost them. There's going to show them what it's going to cost them before the deductible, during the co-pays, while they're paying the co-pays, and what will cost them in that gap in coverage. And then if they reach the catastrophic limit, what it's going to cost them there. And then on the bottom, this is new this year, it gives them a graph and it will show them when they're going to hit the donut hole.
Okay.
So they will be able to visually see, if they're using that screening tool, at what point during the year are they going to hit the donut hole? Will they hit the other side of the donut hole? Will they utilize that catastrophic coverage or not?
So like the donut hole currently goes from 2,250 up to 3,600.
Yeah, and again, those are two different baskets of numbers. You're looking at two different things. The $2,250, that's the total cost, so that's everything. That's what the plan pays and what the beneficiary pays for that medication. The $3,600 is only counting what the beneficiary is paying.
Oh.
So the $2,250 is going to increase a whole lot faster than that $3,600. That's why a lot of people won't see the other side unless they're on a lot of medication. If their medication costs them over $500 a month, then they're going to see the catastrophic coverage. But if it's under that, they probably won't utilize that catastrophic coverage because they're going to their out-of-pocket expenses aren't going to be quite enough. They may come close, but this starts all over again in January. Brand new benefit year. So you start all over with the deductible and all of that.
From the people that you work with, how many, what's the percentage do you see that reach the donut hole?
That reach
Like
the
so
other
far.
side of the donut hole?
No, just reach the donut
Oh,
hole.
I would say easily 80%. I would say easily most people are going to reach the donut hole. Medicare figured that the average beneficiary would have reached the donut hole in September.
But they have all of those 9 months to start, if they're planning
Right.
ahead, to start saving up for
Mhm.
the end of the year,
Exactly.
knowing they're gonna have those
Exactly.
expenses.
Exactly.
Okay.
So that's the basic benefit. And again, the other one is the Medicare Advantage plans. And I gave you, there's really 94 pages to this because it lists all the plans in the state of Texas, but I didn't want to print that all out for you. Again, you can look on the website if you're interested in other counties, but this is mainly Bexar County. So these are all the plans that are offered here in Bexar County. As I mentioned, the plans are offered two different ways. The standalone prescription drug plan, when they enroll in that plan, again, it's just strictly prescription benefits. That's all that they're going to get. This year, there's 47 different plans. Next year, there's going to be 60 standalone prescription drug plans. I was really hoping it would go down, but unfortunately, it's increased significantly. With the Medicare Advantage prescription drug plans, again, these are offered by Medicare Advantage plans. They get the health benefit along with the prescription benefit. This year there were 13 different plans, 4 companies with 13 plans. Next year, there's going to be 21 separate plans, Medicare Advantage, just straight Medicare Advantage plans. And then also there's 14 what they call special needs plans. And these special needs plans are primarily plans for either what they call dual eligible beneficiaries, Medicare and Medicaid beneficiaries, or disease specific. There's one that's brand new. It's a care improvements plan, I believe, that their clientele will either they have to have a diagnosis of diabetes, heart failure, COPD, or end-stage renal disease, and they can enroll in this new special needs plan. So there's an additional plans right there. So there's far more plans this year than there were last year. And again, and it says we have found out now, because their plans were allowed to start marketing October 1st, so we now know who the plans are out there. Just a note on the low income subsidy, because these are pretty expensive out-of-pocket expenses for low income beneficiaries. There is what's called the low income subsidy, or you may hear the term extra help, and this is done. The application process is done through the Social Security Administration. And this extra help, if they qualify, they have to be at 150% of the federal poverty limit. And if they're single, then their resources no more than $11,500, or as a couple, their combined resources $23,000. And resources don't count the homestead, one car, or the belongings inside the home. But if they've got bank accounts, CDs, stocks, bonds, other property, that's what will be counted towards the resources. But if they meet that qualification, then they're going to be eligible for some level of extra help. And really there's three levels of extra help. The beneficiaries that are at 100% of the federal poverty limit, income-wise, that's where you'll find your dual eligible beneficiaries, or Medicare and Medicaid beneficiaries. What the extra help is going to do is it's going to pay for the premium for most of the plans, the deductible, and there's no donut hole. And they'll have this year a $1 or $3 copay. Next year will be $1 or $3.10 will be their copay amount. For the second level, for people at between 100 and 135% of the poverty limit, again, no premium, no deductible, no donut hole, and this next year will be between $215 and $535 for their medications. And those are for medications that are on the formulary of that plan. If that medication is not on the formulary, then they're responsible for 100% of it. And if they're between 135% and 150% of the poverty level, they'll have a $53, or their premium will be based on their income. So it's a sliding scale. So depending on where their income falls in that, they may have to pay 25% of the premium or 50% of the premium. They'll have a $53 deductible, 15% copay, no donut hole, and then when they reach the catastrophic limit, between $215 and $535. So the extra help is available, and again, it's through the Social Security Administration, and you can apply for the extra help at any time. So there's no open enrollment period for this, because people's circumstances change. The federal poverty limit will change in April, so some people that may not have been eligible this year might find themselves eligible next year. So you can apply for that at any time.
So this is a federal thing?
That's a
and
federal.
They call the Social Security office?
Absolutely. And you can go online for the application. It's a lot easier, I think, that the online application than the paper application. Now, Social Security right now is sending letters to everyone that was on the extra help this year. For next year, they're doing a redetermination process. Essentially, if they're still dual eligible, because the state sent records over for everybody that was dual eligible. If they're still dual eligible, they're receiving a letter that says, this is to inform you, basically, that you're still eligible for the extra help. It's good through December of 2007. Let's see. Let me go back. The second group, where you find the Medicare or the Medicare savings folks, people that are QMB, SLMB, and QI1, if they were eligible for the extra help because they were on one of those programs this year, they are receiving a letter, because that group of people were automatically enrolled in the extra help last year. But this year they're receiving a letter that says you are no longer automatically qualified for the extra help but here's an application, you still may be qualified, we need you to fill out this application again. So if you have any clients that are on QMB, SLMB, or QI1, the Medicare savings programs that helps pay for the out-of-pocket expenses, the Part B premium, and some of the out-of-pocket expenses of Part A and Part B, then they're receiving that letter, they need to fill out another application. So we need, if you have any clients that fall in that category, they need to fill out that other application and send it back in, because they're probably still qualified, they're just not automatically qualified like they were this year. And then for everyone else who actually filled out an application because they weren't dual eligible or they weren't on a Medicare savings program, but they had to fill it out but they were found eligible, they're receiving letters right now from Medicare or Social Security saying, this is the information we have on you based on your income, your resources, whether you live alone or not. Has anything changed? And if anything has changed, let us know. And then if you let them know that something has changed, they're going to send you a form that they're going to need to fill out indicating what that change is. If they don't do anything, then Social Security will just match their records up with their IRS statement to make sure that they're still qualified. So if you have clients that are on the extra help, tell them to be on the lookout for one of those letters, because they're going to receive one of those 3 letters anytime. A lot of them have probably already received that letter. But we know that the mail system doesn't always work, or that the beneficiaries don't always read their mail. So that's why, when we're talking to providers, ask them, that's what we're asking you, is to ask them, have you received letters from Medicare or Social Security or any of the plans that you're on? So yeah,
So
Social
the
Security.
plans will also issue,
Not on the extra help, but the plans have to send their beneficiaries, anyone that's on their plan currently, they're sending information about next year's benefits by the end of this month. So they should be getting information about that. So if they have any changes to the plans, any cost changes, any formulary changes, the beneficiaries are being notified this month. So if you can kind of give them a heads up, and so they don't stick it in the pile or throw it away, or whatever typically
I'm
happens
just
with
thinking
mail.
it's gonna be hard to figure out when you get an advertisement.
I know, and see, that's
Yes.
the challenge, because the plans are marketing right now, so they're sending them all the information. They're allowed to start marketing October 1st. Mail, telephone, in the pharmacies, it just adds to their mail intake. So that's why we try to tell people, look for Social Security, Center for Medicare Services, Medicare, Medicaid Services, insurance information. And if you don't understand it, call us. Because we've received copies. Medicare has sent us copies of some of the letters, so we may have an idea of what that is. So it is confusing. Just kind of added on top of everything else. Let's see. Now, the plans are not allowed to market door to door unless they are invited to that person's home. So if you have any clients said that, some representative showed up at my door, that's not allowed. But again, they are allowed to telephone, they're allowed to mail information, and they are in the pharmacies. The enrollment, the open enrollment for this year, and then really for every other year after this, will always be November 15th through December 31st, and the benefits will begin January 1st. Now, Medicare is not going to come out and say this, but unofficially, or what they're officially saying, is that they're encouraging people to enroll or make a change early. And what unofficially they're saying is that really people need to make that change or enroll by December 8th if they want to make sure that their plan benefits start on time on January 1st. Because they're not guaranteeing that all the paperwork and all the systems will be married up by January 1st if they wait till later in the month. So all they're telling people is that they're encouraging them to do it before December 8th. So if you've got clients, again, if we can get them to make those changes prior to the 8th, that way when they go to the pharmacy on the 1st, which a lot of people did this last year, and we saw what happened with that, we try to get them to enroll early. If they wait till the 30th of December to enroll, or 31st, they can do that, and they're still within the open enrollment period. But they can't expect to go into the pharmacy on January 1st, or probably even that first week, and have their coverage work. Now, if they're making a change, if they need to make a change to their plan, they're not happy with their plan they're in, they want to make a different choice, what they need to do is just enroll in the new plan. Don't disenroll from the other one first, because what Medicare says is they're allowed one change throughout the year. If they disenroll first, that's their change. So they just need to enroll. If they find another plan that they want, just enroll in that plan. which will disenroll them from their old plan as of January 1st. They'll still use the 2006 benefit until January 1st. Basically, just things to consider. Whose choice is it? So we had a lot of people. This is, as I'm sure you well know, this has been confusing for a lot of people. So we had a lot of people just want us to tell them what to do. What should we do? And we're not allowed to do that. It's basically it's the beneficiary's choice. What we do is when we do the screening, we find the top 3 plans that are least expensive. And we say, this is what it's going to cost you with these 3 plans. This is what it covers. This is what it's going to cost you. But ultimately, it's your decision. Even if we may not agree with the decision, they want to go with the. And a lot of people chose plans based on the premium, or that it had no deductible or name recognition, or their plans. A lot of the pharmacies are tied to specific plans, and so, for instance, HEB is tied to Aetna, Walmart is tied to Humana, Walgreens and CVS Pharmacy each had 3 or 4 different plans that they were tied to, which confused a lot of people. They thought, well, I go to HEB, I have to sign up with Aetna, or I go to Walmart. I had about a 30-minute round and round conversation with a woman who her plan was working, but she wanted to go to Walmart, so she wanted to sign up for Humana. But the plan she was on was working just fine, but she was convinced she had to do Humana. So I went ahead and enrolled her in the Humana plan because that's what she wanted. Even after, trying to explain to her that she was doing fine. You could go to those same pharmacies and use other plans, but a lot of beneficiaries just didn't understand that.
So what is it tied to? What's that imply then? Just
It's their,
it's
a
more
marketing,
seamless,
it's a marketing tool for the
but
plans.
it's not cheaper for
No.
faster maybe.
They don't get any kind of
No-
extra
no
benefit,
No
no.
benefit.
It's just another plan that they can use at that pharmacy, where they could probably use that same plan other pharmacies as well.
Maybe
But
you can go to that pharmacy and use some other plan
Mhm.
at that pharmacy.
especially the larger pharmacies, you can use most of, if not
Because
all
I've
of the
seen,
plans.
Yeah, like CVS and Ecker, they have Walgreens.
Yeah.
We take all Medicare prescription
Yeah.
plans.
But, so it's probably a benefit to the pharmacy. There's some kickback.
There may be some sort of agreement between the plan and the
But for the
pharmacy.
beneficiary,
There's no benefit.
absolutely no benefit.
I mean, it may be a great plan for them. That may be the cheapest plan, but it's not going to be the cheapest plan for everybody.
And they smile at you better or something.
Yeah. Maybe so. One thing that's going to be different, because this year, I'm sure if you've seen any of the Medicare prescription drug card, the actual cards, they would have, if they had an Aetna plan, they would have HEB on there. Or if they had a Humana plan, they'd have Walmart on there. Medicare is not allowing that this year. So they've taken off the co-branding. As far as the Medicare cards go now, there may be some marketing materials where you'll see co-branding, but the actual cards themselves, which I hope will clear up some of the confusion.
The cards vary from plan to plan,
Right.
obviously.
Yeah, they'll be different for each plan. Each plan won't send their own
It
card.
doesn't look like a Medicare.
No, it's
card.
not like the Medicare card where it's standard for everybody. Every card will have, now they have to have the Medicare symbol on it. They have to have that Medicare logo on it. But yeah, every card is different depending on the plan. Now this process when you're helping somebody to choose a plan, it's going to take time. Our screenings that I've done for people have taken anywhere from 20 minutes to 2 hours. It just depends on what the beneficiary is looking for. They may need to do different combinations of medications, or they may be looking, because one of the considerations to also look at when the plans, because some of them have restrictions. There's 3 different types of restrictions that the plans may impose on specific medications. They can have a quantity limit restriction, a prior authorization limit, a restriction, or a step therapy limit, where they have to try other medications first before that plan will cover that medication. So that may be something that, because I had a client, the one that took me 2 hours was because he was looking for a plan that had the fewest restrictions, and we found one, but it was going to cost him a little bit more, but that was his priority. So, and especially if they're on a lot of medications and they're just explaining it. So sometimes it can be real fast and simple, other times it may be a little bit more involved. We can't make any assumptions about the plan. There's no one plan that's going to meet everybody's needs. It's a very individual decision. Just because it's good for their spouse doesn't mean it's going to be the best plan for them unless they're on the same exact medications. Because the cost of these plans are really driven by the medications they're on. That's what it's going to cost them. Stay away from blanket enrollments. We've heard of places, smaller pharmacies or facilities that will just do a blanket enrollment for everybody in the group into one plan because they think that that's going to be easier just dealing with one plan. Well, that one plan isn't going to meet everybody's needs, or it's not going to cover everyone's medication. It may be more expensive than others. This is again a time-consuming process, and we're just trying to encourage groups not to do blanket enrollments because this year we've seen some problems with that, with groups that have done those blanket enrollments. And then the auto enrollments. This year, if the person was dual eligible, their Medicare, Medicaid, if they had not chosen a plan by December 31st of last year, Medicare automatically enrolled them into a randomly selected plan. But Medicare had no record of medications or anything like that. It was strictly a random decision. They went down the list. And so if someone, but we had trouble with some of the Medicare or dual eligible beneficiaries. They said, well, Medicare chose a plan for me. So I'm just going to stick with that one. That one's easiest. I'm just not. But I did a screening for a woman. She did let us do a screening, and we found that if she had stayed on the plan that she'd been automatically enrolled in, when she'd gone to the pharmacy and if she'd picked up all of her medications, it would have cost her about $600 to do, because most of her medications were not on the formulary of that plan. That plan actually showed up as the most expensive when I did the screening. And so we can't assume that these plans that they're automatically enrolled in are going to be the best plans for them. Now they can make a change. We can change their plans.
Is that one a year?
Yeah. And actually with the dual eligible, so they're dual eligible, and if they're on the QMB program, one of the Medicare savings program, they can make a change one time a month throughout the year. Everyone else is going to be locked into the plan for the year, but dual eligible and Medicare savings folks, they can make a change one time a month. But if you have someone who is automatically enrolled, you really, and maybe they stayed with the plan this year, but hopefully they would have seen what it would have, potentially have cost them throughout the year, and maybe they'll be a little bit more willing to see what else is out there available to them. So it's just, again, just because they were automatically enrolled doesn't mean it's going to be the best plan for them. Now, if we're having, if somebody is having to look at a plan, the first question they need to ask is what kind of coverage do they have now? Again, if they've got coverage through a group plan, somebody else, they need to find out whether that coverage is what's called creditable, whether it's as good as or better than the Medicare prescription benefit. Because if it is creditable, they don't have to enroll in the prescription benefit, and they won't be penalized at a later date because they've got that creditable coverage. They can choose not to enroll. But they need to find out specifically from that company as to whether one, it's creditable coverage, and those companies should have notified them in writing as to whether it's creditable. And everything we've heard is those companies have been very specific. They've said, yes, we are creditable, you do not have to enroll in the plan, or a Medicare prescription drug plan, or no, we are not creditable, you do need to enroll. So they're being very specific. Some companies are saying, we'll wrap around the Medicare prescription benefits, so if you want to enroll in the plan, you can, and we'll wrap around those benefits. And some are saying, we are creditable, we don't want you enrolling, and if you do, it's going to affect your health benefits. So the person needs to find out from their plan, because unfortunately there's no one place to go to find out who's creditable and who's not. So they need to find out from their plan, they need to get that in writing. Now those plans, just because if they had creditable coverage this year, there's no guarantee that those plans are going to be creditable for next year. So they should receive an annual notice from their plan indicating whether they're going to be creditable next year or not. So they should be receiving something right around now from their current plans as to what their coverage is going to be like for next year. Now this year, TRICARE and VA benefits were both creditable. My understanding is that both of those wrapped around the Medicare prescription benefit. But in all honesty, really, it's not going to do somebody, if they have either one of those benefits, it's probably not going to do a whole lot of good to enroll also into a Medicare prescription benefit because they've got the premium and maybe deductible to pay, unless they're eligible for that extra help. So they may find some benefit enrolling, finding out they're eligible for the extra help, and then they would have maybe even just slightly lower cost medication.
So, my understanding with Part D is if you don't enroll, that you will be penalized unless you have credible coverage.
Correct.
So I didn't know that about
Yes.
the credible
Yeah,
coverage.
if you have creditable coverage, you don't have to enroll in the plan, and you will not be penalized. Let's say your creditable coverage ends like 2 years from now. They say, you know what, we're not going to be creditable for 2009. We can't do it anymore. So those beneficiaries would need to enroll within a window of time, but they would not be penalized because they had that creditable coverage up until then. Now, if those beneficiaries had been notified last year and said, we're not creditable, you need to enroll, but they chose not to, then let's say this year they said, we're going to go ahead and enroll in the prescription drug plan, they're going to be penalized. The penalty will, and right now the penalty still stands. There's a bill on the table. There's going to be a very short legislative session after elections that, it's still possible, it could pass. So, but as of right now, the penalty still stands. But there is movement to waive the penalty for this year, not indefinitely. Medicare won't waive it indefinitely, but people are trying to get it waived for this year because it was so confusing. So many people just really didn't understand the implications of all of this. So really, the first thing they need to look at is whether they have current coverage or not, and what that coverage means. Federal employee health benefits were determined to be creditable this year. Teacher retirement benefits, they have 3 different levels. The first level was not creditable, but the other 2 were. Again, the beneficiary should be notified sometime right now or very soon prior to November 15th as to what their coverage for this year is going to be for next year. And they should get that in writing. If they don't receive anything by the 15th of November or don't remember seeing anything, they need to contact that company and ask them where they can find this in writing, where they can find that coverage in writing. Another thing to consider is cost. Again, they shouldn't look at just the low premium or the no deductible. They need to look at the whole package and what it's going to cost them for the end of the year. Ultimately, when the end of the year is all said and done, what plan is going to be least expensive for them.
Now, you say you have a screening, you have a program where you can...
Medicare.gov, there's a screening...
They can put their meds in and then run that through...
Yeah, they can run that through that screening tool on the Medicare, and it's the 2007 information is up right now.
How often do these formulators change? So?
They can change at any time. That's one of the many challenges of this plan, is that the beneficiaries, most of them are locked into the plan for the year, but the plans can change the formulary at any time. Now, they have to give the beneficiary a 60-day written notice.
But then they use their one change.
They can't change. If that plan changes formularies mid-year, they're still locked into that plan.
Is there a history of bait and switch this year?
Pardon me?
A bait and switch. I mean, did they have really...
I don't think they did a whole lot of that this year because Medicare was watching all the plans very carefully this year. But it did happen. Now, I don't know that it happened at a real high level, but down the road we may see that more frequently because the plans are on their best behavior right now. They want people to stay with them. They're trying to cooperate with them for the most part. So I think that may be something we see more of. I mean, we saw it this year, but not in high levels. But I think that we may see more of that as years go on. Also, another thing to look at is the pharmacy. Is the pharmacy within a network of the plan? Because that's going to affect the cost.
So pharmacies can refuse to take certain plans?
Mm-hmm. Yeah, it's up to them. Now, a lot of the pharmacies...
Now, there's an issue with rural places where people are always stuck with one pharmacy or something.
That's something they need to take into consideration.
They just have to look at that. It's not...
Now, a lot of the pharmacies, especially even the smaller pharmacies, were accepting most of, if not all of the plans this year, or for 2006. So I'll be interested to see as the years go on what happens with that. But yeah, I mean, if you've got one pharmacy choice, you need to make sure that the plan you get is accepted at that pharmacy. And then the restrictions, I talked about the 3 restrictions, what's going to happen when you get to the pharmacy and use this plan. Are you going to have some trouble getting that medication? And also, what other programs are the beneficiary on? Let's see, yeah. Are they on what's called the CBA program, or the CareLink, for example? Are they on CareLink? If they're on CareLink, they need to apply through CareLink for their plan, because CareLink is tied to Community CareRx for this year. But they need to go to their CareLink representative and apply for the plan through them. They can't go onto the Medicare website and sign up for a plan that way. They need to apply through CareLink. The Texas Kidney Health Program, if they have end-stage renal disease and are receiving dialysis, they have a special program through their Texas Kidney Health Program where they can help wrap around the benefits, but they need to make sure they sign up for a plan that's less than $35, that they don't have their Social Security check or their premium deducted from their Social Security check, because that's a choice. beneficiaries have to either pay it directly or to have it directly taken out of their Social Security check. But if they're on the Texas Kidney Health Program, they need to not have their premium deducted from their Social Security check, because Texas Kidney Health is going to pay for that. So, I mean, so there's some little nuances depending on other programs that they may be on. One thing that we got calls on are people, when they would go into the pharmacies, they would talk, because those are sales representatives, insurance agents that are at the tables. And we tell people that, not to tell them to stay away from them, but just be aware. But we got a lot of complaints from people that says, well, I went to this pharmacy and talked to this person. They told me that, you know, this plan will cover all my medications, and, you know, of course they sign them up for the most expensive plan. Does it cover all their medications? And this person's on the QMB program, eligible for the extra help. And because of that extra help, the extra help will only pay up to a certain dollar amount of the premium. They pay the national average. So for this year, they paid $31.68 was the maximum premium that extra help would pay for. Next year, it's going to be $27. That's what the national average will be. But these plans were signing them up, or these companies were signing them up for $58 plans, so they were having to pay the difference. That those questions weren't being asked. So that's something that we need to take into consideration when we're helping people. What other benefits might you be on that might affect the prescription benefit plan that you need to enroll in? We got this question a lot. You know, I'm not on any medications. Why should I sign up for this plan? Really, we tell people it's their choice. They don't have to if they don't want to. This is a voluntary program, but there is that penalty. So it's sort of voluntary. It's kind of a forced voluntary enrollment. But, you know, they either have to be okay with paying the penalty. You know, we tell them this is like an insurance. That's the homeowner's insurance and car insurance. You get it just in case. You know, and if you wait till something has happened, of course, it's going to be more expensive after it happens. And so what we tell people is that, you know, an option is either be okay with the penalty when it comes up, or sign up for the cheapest plan. So this year it was $10.31. We say, go ahead and sign up for that $10.31 plan. You're at least in the benefit. It's not going to cost you, you know, that much a year. And that way you're at least in the benefit, and down the road, you know, you're fortunate not to be on any medications now, but 6 months, a year, 18 months from now, who knows what's going to happen. You'll at least be in the benefit. You won't be penalized, and you can make a change during the open enrollment period if you need to. It's just an option that they have. They just need to be aware of that, yes, there will be a penalty. And this year, and the way the penalty works is that essentially it's going to be 1% per month of the national average premium that they did not enroll in, 1% per month that they didn't enroll in the Medicare prescription benefit. That 1% is based on the national premium, not the premium of the plan that they signed up for. So if they signed up for the $11 plan for next year, it's not going to be 1%, it's not going to be 7% of that $11. It's going to be 7% of the national average premium, which this year is $32.20. Next year, if they wait till next year, they don't do anything next year, then they're going to have a 19% penalty on whatever the national average premium is going to be. So, I mean, it's a fairly stiff penalty. It adds up pretty quick on that. And that's how the penalty works. And like I said, the penalty still stands as of right now. We may hear differently in December or so, but as of right now, it does still stand. Roles of the pharmacy. Again, we had talked about this a little bit ago. Is the pharmacy in partnership with Part D, a Part D plan? If they are, they really need to, you know, the pharmacy needs to separate themselves from those plans, because the beneficiaries are going to those pharmacists. The pharmacists are the front line of this benefit. They're the ones seeing the beneficiaries and talking to the beneficiaries about the different issues that they may have. And so the pharmacists really need to be unbiased when it comes to those particular plans. Again, those are insurance agents that are located in the tables offering the cakewalks and the pharmacy cards or the grocery store cards and stuff like that. Those are insurance agents. They're there to sell plans. Most of them are certified to sell one plan. Some of them are certified to sell more than one plan. But really, if the beneficiary goes up to them, talk to them about that individual plan. But unless they're, are they asking about the medications that they're on, the other programs that they're on? Are they eligible for that extra help? all of this stuff, just be aware that they're going to be told that that plan that they're selling is going to be the best plan. Now, it might be for them, but the odds are there's 60 other plans, or far more than that actually. What is it that they want? Again, there's going to be no co-branding on the cards. I already covered that a little bit. So on the cards this year, or for next year, you're not going to see the pharmacy name and the brand name and the plan name. And then if assisting the beneficiary in choosing a plan, should find the plan that best suits the needs of the medication needs. Because again, the cost of these plans are driven by the medication that they're on. If the medications of the beneficiary that they need are not on the formulary, either because they were taken off, they've received that notice that the plan is changing its formulary, or maybe the doctor prescribes a medication that's not on the formulary of that plan. We encourage people to talk to their doctor. Is there any other medications that are on that formulary that they can take in place of that? Now, I realize that there are a lot of medications out there that's the only one that they can take. I mean, there's just no other substitutes for it. If there's not any other medications, they can go through the exceptions process if they want. There's a standard process and expedited process. Basically, it's an appeal process. The beneficiary needs to contact the plan and say that they want to go through the exceptions process. Then they need to contact the doctor, who needs to fill out a form for the plan indicating that this medication is medically necessary and that this beneficiary needs to take this medication. And the plan has 24 to 72 hours to make that decision. 24 hours for the expedited process if it's a life and death situation, and then up to 72 hours otherwise. So they can go through this process. Everything we've heard, Medicare states that the plans have been pretty, a lot of people haven't gone through this, but the people that have, the plans have been pretty accepting of the exceptions process this year. I hope they continue that, but we'll see. But they do have that option. The beneficiary can call 1-800-Medicare. That's a 24-hour hotline that the beneficiary can call if they want someone to do screening. If they want to do the screening over the phone, or they can call us. The SHIP program, the State Health Insurance Program, those are located within the AAAs. Those are our benefit counseling programs. That's the phone number for our agency, the 362-5254, if they live here in Bexar County, or if they live in one of the surrounding counties, they can call one of those two bottom phone numbers. We can do screenings. If they want to do the screening over the phone, we just ask that they have their medication sitting in front of them so they can read off the spelling, the dosage, how often they take them, so they have all that information there. They can go to the Medicare website themselves. It's not keeping any information. You can, on the Medicare website, you can enter in their Medicare information. It asks for their Medicare number, the name, the last name, the date of birth, and when Medicare became effective. And if they choose to, they don't have to enter that if they don't want to, but if they choose to, what that's going to do is tie to the Medicare database and tell them what plan they're currently enrolled in and whether they're eligible for that extra help or not. So that way, because I talked to a woman, unfortunately, she was automatically enrolled in a plan as of January, but she had no idea. She was a dual eligible beneficiary. She was, I guess, tired of paying for medication. She got in contact with her agency, and she wanted to sign up for a plan, and when I went to do the screening for her, I found out she was already enrolled in a plan. So there may be some people who aren't really quite sure what plan they may be enrolled in. So, but you can see, that will allow you to see what plan that they might have been enrolled in.
But if they're automatically enrolled, if it's a plan and that's randomly,
Right.
random enrollment. If it's a plan that has premiums, wouldn't they be getting the premium bills?
No, if they were automatically enrolled, what Medicare did, because Medicare this year they only paid for $31.68 of the premium, that extra help. So they only chose plans that had premiums that or below.
Oh.
And they're going to do the same thing for next year. If they have to automatically enroll any dual eligible beneficiaries, then they'll choose a plan that meets the extra help criteria. And that's on this form right here. The column that's right next to the basic, the benefit type, I guess it's the fourth column over, it says 0 premium with full low income subsidy. If it's got a dot next to it, that means it meets the income or the criteria. Medicare will pay for the entire amount of the premium. If it's If it doesn't have a dot, then the person is going to have to pay the difference between that premium and $27. So this year, but like I said, that we're starting a new year next year. We'll see. I'm sure we'll run into different problems. We'll probably still see some of the same problems, but I imagine we'll see some different problems. Now, I'm going to pass out also a flyer. This is if Medicare came up with a flyer that talks about complaints. If you have a plan, or if they have a complaint about a plan, on the back of that is an email address that you can send complaints out to. I will tell you that Medicare has been very responsive to any complaints that we've sent up this year. Now, the plan is supposed to be paying for a medication, or the beneficiary is having trouble accessing that medication, whatever the case may be. You can send in a complaint to Medicare. And like I said, this year they've been very responsive and have resolved a lot of the problems that our clients may have been having. Anyway, are there any questions about the Medicare prescription benefit right now? And it's a lot of information, and again, we're in round 2 of enrollment. The plans are not allowed to accept any applications before November 15th. So I know some of them are giving out applications already when they're telling them you can't accept it November 15th. Some aren't. But just know that if you hear anybody that says, oh, well, I've already enrolled for my 2007 plan, that should raise a flag, because they're not allowed to accept applications until November 15th. Any other questions on Part D? If I could, I've got a sign-in sheet up here. If you haven't signed in, this is just for my records. I have to show the state that I actually came and talked to people. Just for my information on a separate topic, do you all work with Medicaid and CBA clients? Clients that are on Medicaid, SSI and Medicaid?
Yeah.
And or the
Well, we
CBA
have-
program?
Are you talking about doing?
Anyway, any other questions for me? Thank you all very much. Appreciate you listening to me. If you do have questions, please feel free to give me a call. All right, thank you.
Thank you very much.